So my name is Danielle. I'm a mom of a Candidiasis. She's 10.
Okay.
I'm sorry if I'm a bit.
Okay, bye.
She's currently in hospital at the moment on the IV line. She has got an infection in her toe from Mowbray. So I might have to think a little bit.
Okay, can you hear me?
Yes, good. I can.
Okay, perfect. I just want to see, I've got to, all right, we've already got 5 participants. Panelist 2. Okay, so you've been made a panelist. Do you see at the bottom you're able to share your screen?
Share.
Yeah, if
I click share?
if you need to share something, if you've got a presentation that you need to share with everyone, okay, then you would click share, and then there we go.
Can I do this like that? Hang on.
Yeah, you can, even if you, yeah.
Okay, great.
And then,
How's that? Can you see the slides now?
yes.
Okay, excellent. So,
And then you'll see at the bottom there's a Q&A functionality, there's a chat functionality. Are you able to see those?
hang on. I'm just trying to work on this webinar business.
Somewhere. Should I give it to security? Or should I give it to you?
No, don't give it to me. I don't want anything to do with that. I don't really see, I can't somehow, I guess I have to end the show.
Take some photos.
Yeah, of course. Of me, maybe true. If I think if I end the show, I might be able to see the Q&As, but I don't see the Q&As. So maybe I'm just going to ask people to interrupt me. Like when they come on, like you hearing me, if you talk, will you be able to interrupt me? Is that what will happen?
Let me just see, we've got attendees. So, okay, so there's attendees, and on the side, you've got to be able to choose them and say allow to talk.
So
that.
let me just end the show quickly. Oh yeah, I see Q&A at the top.
Oh, wait. Okay, there we go. I can make you a host. I'm going to make you a host, and then you've got full functionality.
Oh.
So must I still make Janet a host?
No.
He wants full control.
Yeah. Okay, there we go. I've made you a host. Are you seeing the Q&As and the chat functionality at the bottom?
I'm seeing the Q&As at the top, yeah. No open questions, nothing like that, yeah.
Yeah, okay, perfect. So people can put questions in there. Now, if you see, there's a panel.
I see it says remote control, annotate, pause, share, all these functionalities. So if
at the bottom where it says participants.
Yeah.
You click on that.
Yes.
That'll bring up a little dialog box, and there you'll see panelists, and it's yourself and I. I've made you host, and then attendees.
Oh, right, okay.
Scroll over the attendees' names, it'll say allow to talk.
Okay, so should I
basically unmute them? That's if you want to allow it.
Yeah.
Yeah, you see it's coming up on the side now.
Why can't I allow them to talk?
So Nicola, if we allow everyone to talk, then they're all just going to try and talk at the same time.
Yes, but you can mute and unmute their microphones.
So what if they want to ask a question, must they put up their hand and then we just mute?
Yeah, that's usually how we usually find that a lot better. We leave the attendees muted, and then we work off the put up your hand functionality or the Q&A or chat functionality.
Okay.
Okay, so you decide what's better for you.
Okay.
How you feel.
Okay, well they're all muted now, so that's fine.
Yeah, so you've got them all there. If they want to talk and they put up their hand, then you just go back to them and you unmute them, and then they'll be able to interact with you.
Yeah.
Okay.
Okay.
You're a superstar. So are we good?
I think so.
Yeah, you can start your slideshow, and then it'll, sharing the screen with everyone. If there's anybody else who's talking, is it just yourself, Dr. Peters?
Yeah, it's just me, and then people from the audience will hopefully...
Yeah, okay, that's perfect. Then you're the only one who'll need to be able to share your screen.
Yeah, it's just unfortunate that the audience here in Cape Town, they won't be seen. Maybe they're happy about that, but it would be nice if they were, when they asked a question, the other patients could see them. But it's not an issue.
No, it's fine.
It's
This
not
is
an
good.
issue.
Perfect.
You're a superstar. Thank you so much.
Shame, no problem. I'm going to mute myself so that you don't hear all my background noise.
Okay.
Perfect.
Okay, and then when you're done at the bottom right-hand corner, it says leave meeting, and then that'll end the session.
Okay, and is it recording this?
Yes, it is.
Brilliant. Thank you so much.
Pleasure, no problem.
Have a great day.
You too. Bye.
Bye.
Okay, there you go. That's perfect, actually.
Ooh, so
Okay. There you go. That's all working. I think we're good to go.
are we ready to go?
Yeah, yeah.
Do you
So
need
I
to
heard
wait?
you. So you're going to look after your child.
Well,
Yeah.
she's sedated, so I think she's okay.
Shame.
I'd like a sedation, but I think she's fine. Should we? I mean, it's 10:05. Do you think we should wait another 5 minutes, or should we just go for it?
Well,
You
we
guys
can. I think we
decide.
can start. I was
Let's
hoping to
start.
leave it quite informal,
Yeah.
right? So I've got slides to show you, but the focus of today was to try to give you some information about genetic testing, right? And to kind of talk a little bit about, and this is where I wanted to be interactive. You can ask me questions because to some extent it is actually an individual conversation with your practitioner or your medical practitioner in making the decision. But what I'm trying to provide and what I've got is a few examples of cases where it has been of benefit, and then also show you cases where it hasn't been of benefit or where it's actually been a bit confusing and problematic, right? So that's the thing about genetics. It's not a clear answer for everyone. And then also I will give you some data from big international sort of groups, which actually give you sort of very realistic statistics on what you can expect in different conditions, right? Because genetics, the field, and I'll also show you the costs and how even the costs from 2015 to 2019 are completely different. So it's a very rapidly changing field. And probably if I give this talk to you guys in 2 years' time, I might say a different thing. so it's a kind of very quickly evolving field. But hopefully as kind of patients and parents, I think that you will have unique perspectives. So I also want to hear from you. And so we can have that. So my talk is not that long. And then I hope that we can actually just have a specific discussion.
Yeah, and I think that's really important because I think for an adult patient, you know, you're making a decision for yourself, you know, and you've obviously been in a long progressive way with your PID. Whereas for a young child, it's the parents that are making that decision, and it's two very different sides of the coin. So I think it's really good that Dr. Peter does, you know, attack both sides of the coin for you, because I know that we've investigated this as parents and we're kind of teetering on the edge. So that's why I'm really excited about this talk, because that'll kind of seal the deal for me or not. So yeah.
Cool. Okay, so we'll go ahead. So feel free. Can you all see that now? I think leave the lights on maybe. Then you can all. And then I can give you these slides if you want. I'll just send you the slides if you want. There's the coffee. Prosper, you can use my cups. If you want paper cups, maybe. Oh, you can use those. Okay, fine. Who wants? We've got an array of coffee here.
Oh, wow.
Yeah.
Just coffee.
Like there's what do you have? Americano.
Wow,
There you go.
Should we? Do you need their name and then their order?
No, I think just let's order it and you can, Prosper will bring them in and just give them.
Yeah, I don't know.
Sorry, to everybody listening, we're just getting coffees, which is very important.
Is this your full-on barista? Okay, you're very spoiled. Just a question that someone has just asked me. Michelle just asked me now. Michelle was wanting to know about the Zoom. So the reason why we did Zoom is because it's recorded, and afterwards we'll be able to give it to everyone, and you'll be able to watch it whenever you want. So don't panic too much. But I know if you want to make notes or something, I'll organize things.
Sorry, someone
Flat white decaf. Decaf.
Is there anything else besides coffee?
No, chai tea.
Have you ordered?
Okay, is everyone sorted?
Jack, have you ordered?
Yes, I was the one.
Hot chocolate, okay. Ctla4.
You ordered.
I'm so ordering. So excited. I love coffee. Okay, so we ordered.
Okay, thanks, Pastor. All right, okay, so I'm going to kick off, I think. So just to, I think Danielle introduced me a little bit, but also just to tell you a little bit about my background. So I've got two kind of places we see patients. So I head up the Allergy and Clinical Immunology unit at UCT, which is at Groote Schuur, which is linked to the public hospital. So I see patients there at Groote Schuur Hospital. We have two or three clinics there. We also link with Red Cross. We have a combined adolescent and child clinic there that we link together with the pediatricians in terms of dealing with some of these complex problems. And then I run a private clinic, which is upstairs on the 4th floor here, which is focused on allergies and clinical immunologies. It's so in different parts of the world, training is different. So in some parts of the world, you can become an allergist alone, but in most countries, you become a combined allergist and clinical immunologist. The discipline links together. And so, yeah, so I predominantly I trained as an adult physician. So my background speciality is in adult medicine. So I tend to look after adult patients, and I have several of them that infuse at the UCT private hospital. There's a chemotherapy infusion rooms that I use for immunoglobulin therapy administration. I've got some patients, several patients on subcutaneous immunoglobulins as well. And then in terms of children, I always like to look after them with their primary pediatrician. I'm not a pediatrician. I don't like to work out child doses of different medicines. So I'm happy to look at people's immunology. And so I often get sent patients to look at from that perspective, right? But I'll tend always then to refer them back to their primary pediatrician for their ongoing day-to-day care should they get an infection or something like that, right? So, and because I also do have quite a lot of research, and I'm in the States, I'm limited in terms of the amount of private practice I can do just from my job. So I can only do like essentially one day. Theoretically, you shouldn't even do that in your working hours, but it's a bit flexible. So I sort of manage, but that's why sometimes it's quite hard. And that's why I also will often, even with adult patients in private sector, want them to have their primary treating physician that I can then just advise in terms of their immunoglobulin. So that's my own background. And so, as I mentioned today, what I'm going to talk to you a little bit about is examples. I'm going to give you a few cases examples and then some data from consortia or international thing about specifically genetics in the context of primary immunodeficiency. So let's try and move forward here. Okay, so I think there's some settings where genetics is the complete obvious choice, right? And so the first instance I'm going to talk to you about are children presenting with severe combined immune deficiency. These are children that are basically would die without intervention soon after birth, right? So there are some immune defects which lead you with a multitude of problems in your immune system, where essentially stem cell transplantation or giving you a new immune system is the only hope of survival, right? Those children, if they are not picked up early in the first few months, tend to really struggle and often die, right? And in fact, we have those warning signs for primary immunodeficiency. Those are families that have had a child like this. That's the best hope of picking this up in the next generation. In some developed country settings, they've now moved to newborn screening, right? So that's using dry blood spots where they will screen all newborns will be screened. We do not have in this country yet the resources to do that, but there are methods to essentially they look for a white blood cell called lymphocytes. They look to see, are you making enough lymphocytes? You can look at that in a very young newborn, okay? And of course here, it's very important if you can identify, and that's why actually one of the roles of a primary immunodeficiency network is to bring this awareness to families that may have had an affected child, to raise this for the next child, because we give BCG at birth, right? That's our national vaccination schedule, is to give the TB vaccine. Now, BCG is a live vaccine. And one of the things is that if you know that you are at risk for a child with severe combined immune deficiency, then you would not want to give any live vaccines, right? So it's very important early management. Now, in those cases, early identification and then a genetic diagnosis, or having a genetic diagnosis in the family when you're planning the pregnancy is beneficial, right? So those are the obvious cases where undoubtedly genetics really helps you plan future pregnancies, so that's the one aspect. Then the other is also a group of severe combined immune deficiencies effectively, but that might not present with overwhelming infection right at the beginning, right? So then it becomes a bit more difficult, right? So the diagnosis is not necessarily obvious straight away. So the one I put up here was actually from a case which was diagnosed in Cape Town by one of our pediatric allergists, but is a combination of presentations, which includes severe allergies, looks like severe allergies, and then severe gut problems, right? Very bad inflammatory gut disorders, and then often autoimmune endocrine problems, right? So patients that present with type 1 diabetes or severe eczema, okay? These kinds of severe autoimmune manifestations, again, should alert you that there is some kind of problem very early on, right? And this particular case that I put up here was a case where, I don't know if I've even got this next slide, I might not have put it in here. Yeah, I didn't. Was a deficiency of Fox P3, okay, a gene defect in Fox P3, which is a gene that controls your regulatory T lymphocytes. And those lymphocytes are what keep the balance in your immune system, right? Because the immune system's job is both to recognize dangerous infections and pathogens, but also to shut things down once the immune system's been woke up, right? You've got to be able to calm it down. And if you don't calm it down, you can start targeting your own tissues, and then you get all kinds of autoimmune mischief, right? So the immune system is actually always a very, very tight balance. And we see this, and we've increasingly recognized this in primary immunodeficiency. We increasingly have recognized that simultaneously people can have risks for infections. So they have immune deficiency, but they also have what we call immune dysregulation. So they're at risk for autoimmune disease as well, right? So actual inflammatory diseases. And it's something that even doctors are still struggling with, right? I often have many conversations with doctors when I say that I want to give primary immune deficiency patients immune suppressive therapy, right? They don't understand that freaks them out, right? And it's because of this balance at the immune system. So here's a good example of that, right? So in this instance, it was a complex set of medical problems where a genetic diagnosis was what was needed, and essentially clinched the diagnosis. So we knew what the problem was. This child was given a stem cell transplant and is cured. Okay, they've gone from being almost 100% likely to die to being likely to have almost near normal life expectancy, right? So these to me are the situations in primary deficiency where genetic diagnosis is obvious, right? So if this kind of severe manifestations, it's a clear example, right?
Sorry, Johnny.
Yes.
What sort of age was that diagnosis made?
That diagnosis was made at about 18 months.
Wow.
Yeah, so very, very young. But again, the severity of the early presentation was what prompted all the warning signs to go off to pursue a genetic diagnosis. So that's what I'm saying. So severe early life presentations, to me, there's the risks, the benefits are far in excess of any fact that you might get a no answer. I mean, it still happens. You might not get the gene. It might not be a genetic problem that's easily amenable. But if you do, the therapy is like black and white difference, right? You transplant the patient and the outcome is 100 times better. Okay, and otherwise the patient's almost certainly to die. So that was this. So this child here. So this is what I put up here. So present with severe like eczema, very bad. It looks like the child's got incredibly bad allergy. Actually,
So all those symptoms, one patient.
Yeah.
Yeah.
So
I thought that was just like a generalization.
No, that is, but I'm saying that is also the features of this particular Fox P3 disorder. But this patient that I'm talking about had severe dermatitis, had multiple food allergies with very high levels of these eosinophils, had developed an autoimmune cytopenia, which is where like your red cells or your platelets go down very low due to autoimmune. So actually had all of these features, right? And so that was when the alarm bells went off, where a genetic diagnosis was pursued. And in fact, that was still at the time where they weren't, and I'll show you what's available now, where you actually, the clinician had to seek out another doctor doing the group that's doing research in England, send them, and they looked specifically for that gene problem, right? So that was like what we call a single gene. They thought that this looked like this condition that was described. This is called IPEX, okay? It's an X-linked, it affects boys. Okay, and it gives you this endocrine, polyendocrine problems as well. Okay, so that. It was done here. It was done here. Yeah. We can talk about those. I mean, that's the whole sort of care about where these things should be done. This is more like, I'm just trying to say, this is somewhere where genetics is absolutely critical, okay? And then I mean, we even have cases where we have moved to transplant for severe combined immune deficiency without a genetic diagnosis, right? But everyone is much more jumpy. It's more scary, right? You're not sure, because remember that the other thing about it is that not all gene abnormalities affect the immune system in isolation, okay? So what you can be, and when you do a transplant, a stem cell transplant, you only correct the problems in the immune system, right? You give somebody a new set of progenitor, like early cells that make all the immune lines. That's what you do when you give someone a transplant. It doesn't affect, if there's something that affects, say, the skeletal or the ectoderm, right? You won't change those problems. You see what I mean? You're not like giving the person a whole new set of genes. So the reason for wanting a genetic diagnosis in this thing is that you can know, so Fox P3, which is this condition we were talking about, it affects regulatory T cells. It doesn't have that many important roles in other organ function. So what you know is that if you correct that problem, you give people new regulatory T cells, then you're going to fix them, okay? It becomes more complex when you are not certain. There's a whole lot of things going on, and you're not certain if I just correct this person's immune system, am I going to make them better, right? That's where you've got risk, because there is risk for the transplant, right? It depends which center you go in the world, but can be up to a 10% mortality rate from around the transplant, right? So it's a high risk procedure nonetheless, right? But in early severe combined deficiencies, the success of transplant is very good if you get it early without a lot of infections, right? So the earlier you diagnose it, the more you can, like, if you can be, the ideal scenario is like in families where you know a defect, then you can screen the newborn. When the newborn comes out, you isolate them, you transplant them. Like, that's actually the best outcome normally, right? Those patients almost always survive, right? So that's where it becomes very important to think. And that's where genes can really help you. You can be like, we know what the defect is. We know if we fix this, it just gives you that like strength of conviction to undergo what's quite a risky therapy, right? Okay, and so and also what I'm going to talk about later is it's also more complex when you look at some gene defects where we don't know, and so then it becomes a little bit more. But these are the obvious ones. I wanted to start there. This is where clear, like, no problem, it's going to make a difference. So then I'm going to give you an example here of a patient that saw me. It was an adult patient, age 37, with severe fungal infections, right? So she had something which we call chronic mucocutaneous candidiasis. And that's what I put here. You can see in this this is a genogram or family tree. And you can see here the CMC. I don't know if you can read that. Okay, but that stands for chronic mucocutaneous candidiasis. And she'd suffered with this all through her life. Okay, and to the point where she actually developed esophageal strictures. So she it affects all your mucosal linings, right? So including your esophagus. And the complications of this chronic inflammation is that you can get like narrowing and strictures. And in fact, if you look here, you'll see that her father, in fact, died of esophageal cancer as a complication of this process, right? And so she came to see me. She'd had no problems with recurrent infections other than this fungal inability to deal with fungal and disease. She interestingly also had abdominal TB. But when you took her genogram, you'll see this, right? So this is the patient that came to see me. What you'll see is that her dad died of this and also struggled with this, and her son as well, right? And when you see this pattern, so what you see here is you see a disease where you've got an infected individual in each generation, okay? And then the other thing you see is you see that you've got men and women affected, right? So it's not like a X-linked condition that's only going to affect one gender. This almost always indicates that you're dealing with what we call an autosomal dominant disease, right? Which means if you get one wrong gene, you will manifest with the disease, okay? So unlike what another form of disease called autosomal recessive, where you have to get two bad copies, right? Remember, you get a copy of genes from your mom, copy from your dad. And basically you need to have, in some disorders, you need to have in some like genes or proteins, you need to have two functioning genes. Okay, so if you have one not working gene, you will get some form of disease. And in other diseases, one gene can be enough to give you a sufficient protein function or whatever the gene does to be okay. And you need two that are wrong in order to get some kind of problem. Okay, so when we saw this, fortunately, this is where it helps to have people thinking. This field is changing so fast that actually, people going to conferences, like when you go to conferences, the reason you go there is you'll sit in the audience, they'll describe a new gene and you'll go, hey, hang on, that patient that I saw, the other day, they've got those 5 things. And often this is happening. Clinicians are going there, they're seeing, oh, that fits with this patient, and then like it's coming. And that's I had heard about this gene before, and you can see this is a gene called Stat1, okay, which is a signaling gene, and this was first described only in 2011, okay. And I sent her genes. I sent to the NIH, specifically asking a colleague to look at this gene, and she of course has this, and it's in her son as well, and most likely in her father as well, right? So we were able to confirm this genetic diagnosis. But why did I put an explanatory? Now you can argue what's the point of this. All right, you might ask me why do we need a gene diagnosis? We know she's got that. Well, the first thing is that in terms of her son's children, right? Okay, so they can now, because now there's a 50% likelihood that her son will have an affected child as well. Secondly, there's quite a lot of data, there are cohorts, huge cohorts, we can know what to expect, right? So these patients sometimes develop endocrine problems. So we can monitor, right? We can monitor and pick up early when anything like that happens, okay? And then the other thing that was interesting about this is that she described to me, when I explained this to her, she actually called me like 3 days later, and she said that her mom, when she'd heard this, had started to cry, okay? And one of the things she said is that her mom described how when they were young, they had gone on a cruise across it was obviously the early time when you used to take a cruise on a ship, like transatlantic or whatever. And apparently they'd stopped in some island where her and her brother and a whole lot of kids had swum somewhere, and like her father and everyone had swum there. And a couple of kids had suddenly got sick after that. And 1 or 2 of them had died, okay? And they'd never understood this. And they had felt that she had been affected, and that somehow they had been affected by that. And this was the cause of their disease, right? And they felt that this had been transferred, that somehow they picked something up from this cruise, and that somehow this had been transferred. And that was their explanatory model of how this disease had affected their family, right? And so having this answer now completely transformed everything that the mother had thought about with respect to this whole condition, right? And so it was something that I hadn't even thought about, right? That's why I'm telling you, it was an interesting spin-off of having a genetic diagnosis where the whole explanatory model was so much, in a way for her, so much more, it was a relief, because she thought maybe this would carry on indefinitely or how it would work. It changed everything about the way in which they thought about this thing. So that to me was an interesting kind of spin-off. So So this here is kind of what I was mentioning, right? So improve the understanding, heightened surveillance that I was talking about, increased awareness of TB and esophageal cancer screening. Remember that her dad died of that. So this disease is treated with aggressive antifungal therapy, and you often need cycles of that, but you also need surveillance to pick up cancer early, should it arise, right? Because esophageal cancer, if picked up early, can actually be treated, right? Okay, and then of course, genetic counseling of the children is an option. And similarly, I put this case in here because this is another gene that causes chronic mucocutaneous candidiasis. And this was a little boy that I was following up when I was in the UK. And what's interesting about this is another gene in a gene called AIR, which is a very pivotal gene when early on in the immune development, when your immune cells are getting educated as to what is your body and what is the external environment, right? So all your immune systems, your cells go through like a programming. It's like going to school for immune cells, basically, right? So it's the education for lymphocytes. And basically what the lymphocytes learn is they learn what your tissues look like, right? And there's a gene in the thymus, which is where this happens, which has got the incredible ability to be able to expose your immune system to all sorts of antigens from all other parts of your body, which the immune system wouldn't sell. Like, for instance, the pancreas is a great example. The pancreas has got particular genes which are switched on in your body, which aren't in the thymus, but this gene has ability to like show the developing lymphocytes, this genes of your pancreas, so that when your lymphocytes come out later, they don't then target your pancreas. Because of course, if you target your pancreas autoimmune, you get type 1 diabetes, right? And so that is the autoimmune nature of type 1 diabetes. And these patients, they all develop multiple endocrinopathies because this gene is faulty, right? And so this is a situation where it's really about surveillance, right? So every year, this young boy has a multitude of endocrine assessments, because should we pick up one of these things early, we can treat them, right? So that's another example. So then this is another patient that I've looked after, and she's actually doing very well overseas now. She's an adult, but she basically was from early on was a child that had multiple respiratory tract infections, right? Okay, multiple hospitalizations, IV antibiotics, and then she had this very interesting immune phenotype, which is described as hyper IgM. Okay, so if you look here, I've said there that her IgM value sits at 10.9, right? The normal hyper IgM is about 2. Okay, that's your normal level, 1 to 2. So you can see how very high that is. So she has this a feature which is of very low immunoglobulins, IgG and IgA, these other isotypes, and this high IgM, right? That's got a particular group of genes and problems that cause those conditions, right? Now, what's interesting about that is some of them are very dangerous and give you other immune problems, and some of the genes are less dangerous, right? Okay. Fortunately, she is a girl, which means that the genes the problems she would have tend to be less severe, because the X-linked form of this condition is the one that's very dangerous. Okay. And she also didn't clinically have any evidence. When I say here of cell-mediated immune defect, these are the patients that get at very high risk for other kinds of very bad infections, TB or other opportunistic infections, right? And then this is really a kind of tribute to how patients and yourselves or parents advocate with interested clinicians to get to a diagnosis, because this was long before there was any kind of ready available genetic testing like we have now. Okay, and this was a great effort through Monica Esser, who some of you know as well, as a pediatrician, and this patient's mother, to get a diagnosis at the Necker Institute. Okay, and there she was. I won't bore you with that detail, but basically she was found to have this heterozygous mutation in a gene called adenine inactivation deaminase, activation-induced deaminase, AID, which is a gene that helps your immune system change from making IgM to making IgG and IgA. Whoa! Oh, shame.
I'm so sorry.
No worries.
I'm really having a
Are you
terrible
okay?
time.
Are you okay?
I just burnt your barista.
No, it's okay. It's
And
okay.
myself.
Are you okay?
I'm so
Let me
sorry,
take
guys.
that.
I really
Sorry, hang on.
I'm not cross. I'm so sorry. I'm really. I want to go. I'm sorry. I'm so worried about Kate. I'm so sorry. Yeah, I just really didn't want to disappoint all of you and cancel. But I'm going to go because I'm worried about it. I'm so sorry I've ruined you. Are you okay? Gosh. I'm so sorry, guys. Shame some of you I haven't even met before and I'm not sobbing like a crazy person. I'm going to come back later. Sorry. Are you okay? Sorry, guys, I just burnt the barista. Are you alright? Did I? Oh, your clothes and everything.
Okay, you're right.
Oh, I'm so sorry.
Maybe we can keep those copies out there.
Yes, thank you. Okay, I'll see you later.
Jonny, take a deep breath and relax.
Tell you. So you can't come back, don't worry. Are you locked up for me?
Okay, who wants a latte?
I'm gonna
I'll
skip
sort
my-
it out for you.
Yeah,
Sham,
thank
I'll
you.
make sure everyone's okay.
Oh, you're
That's
so
it.
bad. Oh, what a day. Sorry, guys. I promise you the next one will be better. Okay.
Latte, another latte.
My head is not in the right.
2 lattes up there.
Sorry. Oh, that's so sad.
Black white, white.
I was trying to be so quiet and
Black white. Black white, black white, black white.
I'll see you all later.
And no one remembers what they ordered.
I don't even know. No one knows what they ordered because I've got
This is a black white. This is decaf. No. Black white. Oh, shit.
I'm so sorry,
No
guys.
worries,
I'll
no
see you
worries.
later.
Okay, thanks, Prosper. Just come in, we can interrupt. Okay, we're back here. So I won't bore you with this detail, but essentially this, what's interesting about this gene, right, is of course this is some fancy kind of genetic explanation here, but essentially this is, she was very unlucky, okay, in that she inherited a bad gene from mom and a bad gene from dad, okay, and she got autosomal, essentially a heterozygote, she had 2 bad genes. And what's important about that is her children won't be affected unless her husband happens to also have a bad gene, but that's unlikely. Do you understand what I mean? So she will not transmit this condition that she has to her children, okay? Oh, so basically, so what I'm saying is she has, this term is a technical medical term. It's called a compound heterozygote. And what that means is that you got 2 faulty genes, one from mom, one from dad, okay? So essentially you've got yourself what we call an autosomal recessive condition, right? And autosomal recessive conditions, because if you marry someone, you only give one of those genes to your offspring and your partner gives the other one. It means that your children only inherit one bad gene. And as long as your husband or your wife doesn't have another bad gene, your children won't be affected by the condition. No, this is the patient. This patient has immune deficiency. She was a patient that had multiple infections, that her mother spent a lot of time knowing, you know, she's got immune deficiency, all right? But her diagnosis from a genetic point of view, this is why I was putting this case in here. She has come to me, she's currently doing fantastically, living overseas and wanting to have children. And that's one of the things she asked me. She had already got a diagnosis in childhood, okay, through her mother being so resourceful, okay? But the impact of the diagnosis, it didn't change necessarily her treatment, right? Because she's on immunoglobulin replacement. But it helped in not only understanding what she's likely to develop, okay? So fortunately, what's good is that these patients have a good prognosis if they get onto immunoglobulins. They tend not to give any other problems other than increased infections, right? So it's unusual for them to get other, you can see here, they've only got, so about a 20% chance of autoimmunity. So they can develop it, but relative to some other immune problems, it's not a bad one to have, okay? But more importantly, counseling her around her children is important because she basically is not going to pass the condition. She'll pass one of her genes, but she's not going to pass the condition on to her offspring, right? So when you counsel her about pregnancy, it's very easy to counsel her, right? She should definitely have children, basically, and she should carry on. And by the condition, I mean, she's well controlled, and actually, if she takes immunoglobulin, she lives largely a normal life, right? Okay, it's a bit inconvenient to take immunoglobulin therapy, etc., but essentially should be able to do everything she wants to do, right? And that's obviously what we hope for patients with primary immune deficiencies, that we can get them to have a normal life, right, as much as possible. So again, that where, to me, an example of how genetics can be very important, okay, in aspects of care and also in aspects of kind of information related to the patient. Okay, so this is now where I'm going to start to get a bit murky, right? Now, those are the clear ones. I'm giving you some examples of how nice it can all work out, right? Okay, but what about this young girl? This is a young girl that I look after. Well, I started looking after her when she was 14. She's now 19. She's had long-standing hypergammaglobulinemia, so that's low antibodies. Okay, so she's on, and she's done quite well on immunoglobulin replacement therapy. But then when she was 8, she actually developed seizures due to low blood sugar, hypoglycemia. And she was found to have a very, very unusual thing called ACTH deficiency. So essentially, ACTH stands for adrenocortical thyroid hormone, and basically, tropin hormone. And basically what it does is it stimulates your adrenal to make cortisol. And you need cortisol to keep your sugar up, to help you to fight infection, right? So this is like an isolated problem with one of her pituitary hormones, okay? And then she actually came to see me when she started having problems with things in her lung, right? There was infiltrate, she was coughing, she found things in her liver. And we actually we didn't know what this was. I thought that this was something called lymphoproliferation that's often benign, that's associated often with immune deficiency, like I was explaining to you, because she's been labeled as having complex, common variable immune deficiency, or CVID, you might have heard that, right? But what I didn't like about that is the ACTH deficiency. That to me was something that was a flag that this could be something else, some other gene, some other problem, right? And then the other thing is that she's had quite a really rocky course over the last 5 years, where she then developed acute renal failure due to some kind of unknown obstruction in her bladder, okay, which I think was also this infiltration. And then at age 18, so just like almost 18 months, 2 years ago, they found a diffuse B-cell lymphoma in her knee, okay, which actually was disseminated everywhere. And she's done very, very well, fortunately, on chemotherapy, okay, so she's currently in remission. But you can see clearly a complex set of problems, right? Now, when I went looking again, so often what's important is when you find something that sticks out to you, you look and see what it is, right? And so there were these 2 papers that I found. So mutations in this gene here called NF-kappa B2, and something called David syndrome, right? Which you can see here, deficit in anterior pituitary function and variable immune deficiency. Doesn't that sound exactly like the patient? Okay? It does, yeah. So I was absolutely convinced that this was the problem. I told the parents, and then I contacted this group here, Terry Brews, a French group. I emailed them, and I got consent, and we sent off the genes. This is what I got back from the French group. Sorry, we don't find anything. Would we like to look in some of these other genes? I hope you feel better soon. Anyway, so I was like a bit disappointed. I thought, okay, well, I'm sure that I'd found the genetic diagnosis. And this, can happen with genes. Sometimes you can have what's called very heterogeneous presentation. So in other words, you might have a particular clinical appearance, but you might have several genes that might give you that same clinical appearance, right? So I thought, okay, fair enough. But this was before she got that B-cell lymphoma. When she got that B-cell lymphoma, I said to myself, she must have a genetic diagnosis, right? She must have, because you see, a number of adult patients with common variable immune deficiency have what we call polygenic disease. Okay, so they don't have a single gene defect that's causing the problem. It's likely to be multiple small abnormalities or small genes that are unfavorable, and that's why often the disease only presents in adulthood, right? But when you see this, when you get a blood cancer, basically under the age of 20, you have got a gene defect, an immune gene defect, right? It's just, where is it? Okay, so I then went back and again, Monica's S's group, together with some other researchers in Stellenbosch have set up some whole exome sequencing. Okay, and what that is that's when you look across the gene at all the protein coding regions, right? So your genome is very, very big, and only a small section of it, right? You can imagine if there's like a big pie, then basically this tiny segment like this is the genes that actually code for proteins, right? The rest of the gene is actually what we call non-coding, okay? And basically when you look at those genes, those are the ones that most likely, when there's a problem in one of those genes, means that there's a problem with the protein, means that there's a problem with function, right? So we can now where this gentleman, where this French group were looking only at that one gene, right? They were only looking at the NF-kappa2b gene, right? They looked only at that gene. I said, okay, well, if it's not that gene, we have to look more broadly. So then I said to Monica, can we do whole exome sequencing, okay, on this girl? Now, interestingly, what was turned up was that I was right in the beginning, okay? Because actually what they found was a new mutation, okay, in that gene, that same gene, right? Which means the other point that I'm trying to make with this case is that sometimes genetic testing can be wrong, right, at first go. So it's not perfect, okay? So just because you have somebody come back and say there's no gene defect, doesn't mean there isn't something actually, right? There's a small possibility that all the techniques have got advantages and disadvantages, and none of them are perfect, okay? So you can miss it, right? And so you sometimes have to still have strength of your convictions, right? Now, what's interesting, and the reason I put this up, is you can see here, this is her gene mutation in a particular region of the gene. And you can see here, this is the region of the gene with all the known mutations. Hello. Yeah, so what they did is they do whole exome sequencing. So this is where it starts to get really technical with genes, right? They basically, what it is that you map out all the nucleotides, right? So essentially your DNA code is made up of A, C, T, and G, right? They're just in different combinations, okay? And it's like a long code, okay? And basically what you have to do is they're now all these software programs, right? So there's huge amounts of computer-based technologies. And what that does is it takes your genome and it knows the regions how the coding sections where it would translate to proteins. And if you find something like this, a new variant, what they do is they take it and they can predict, and I'm going to talk to you a little bit about the grading, but they can predict how bad, is it likely to cause a problem? Do you understand what I mean? Using software, like essentially huge amounts. They compare it to the other normal genomes, okay? And then they also look across the family. So that's also helpful, right? If you see that, say you've got a family and you've got normal members and then a person with a problem, you can see that the normal members have a normal copy and then the affected individual has a different copy. That's when it works nicely. Then you can say, okay, well, this gene defect occurs in a part of the gene which looks to be causing a problem. So in other words, like let's say, for instance, a gene codes for a protein, right? And a protein consists of what we call amino acids, all nicely packed, and they got to fold and make a nice protein. If, for instance, halfway through your gene, you have a gene defect, which means that the amino acid sequence stops. Like it goes from coding for one amino acid to coding for the protein to stop. What that means is you're very likely there to have a problem with that protein. Does that make sense? And so and then the software will tell you, okay, that gene, that place that you've got a mutation is very likely to cause an issue. Does that answer your question? Yeah.
Sorry, Johnny, just one more quick question. Just out of curiosity, would this information then be shared with the group in France then?
Yes, correct.
To further their studies?
Correct, yeah.
So was it an anomaly that they hadn't been aware associated with that gene then?
Yeah, correct. They hadn't looked, so they were looking probably down here in this region where all the other defects were, right? And sometimes it's also just the bioinformatics. They might have, the difficulty is that you can, when you in the software stage, when you like in the bioinformatics stage, you might get like 2,000 variants in the gene. And then you have to narrow it down, look, and then again, even this gene variant, right? There are some scientists that would argue you still cannot be sure that this is actually causing, thanks. Everybody got coffee? Everyone happy?
Delicious, thank you.
Thanks, Prosper, appreciate it. So you still kind of be sure, right? They want you to do functional testing on it, right? However, in this gene, with the clinical disease, you can be fairly sure, okay, within reason. Okay, so this is where it gets, now that's why I said this is less clear, right? Because I'll show you my next slide, right? So this actual gene is suddenly kind of emerging as one of the genes linked with the common variable immune deficiency phenotype, right? When I say phenotype, what I'm meaning is the clinical presentation of that, right? And this was a poster which is looking at this particular gene, okay? So I saw this at the most recent European Society of Immune Deficiency meeting, okay? Because one of the things you do is when you find this kind of variant, what you must try, one of the useful things that I'm interested in is how do I counsel the parents and this girl, right? What should she do? How does this gene affect her, all right? So where possible, what's very useful is if you can find information on other people that have similar genes that are published in the literature or that other scientists or doctors know about, you can start to see what the spectrum of conditions is that is possible. You know, how likely is this? Are these patients, you know, like I mentioned for the previous patient, the information we have suggests that abnormalities in that gene are actually most of the time going to be fine. They're going to give you immune deficiency. If you take your immunoglobulins, you're probably going to be fine. You know what I mean? Like, so we can give some good counseling based on what we know. Where it becomes tricky is that's a new variant in a strange part of the gene. What can we see? So that's why we go and look at other people. And you can see here, this is a family that has a child with a similar mutation in it, right? And you can see they get recurrent infections, but they also get this lymphocytic proliferation, which is what I think she had. Okay, and then they do look here. She's getting this is a leukemia. Okay, and this is quite a severe disease, right? So actually, there are some parts of, so that's the other thing that's complex in genes, is that you can have a gene abnormality in one part of a gene and have quite a mild disease, and you can have a gene abnormality in another part of the same gene and have a much more severe problem, right? So that's the issue. So the question, and I put this up, and I'm currently with the family currently discussing this, right? Because it's a case of now what? Like, what do you advise, right? And we are still in the process of describing this, because you could argue that that the evidence we have suggests that this is quite a severe phenotype. Clinically, we've also seen that, right? She's more severe than other people. She just is currently with treatment for her lymphoma, right? So there are clinicians which might argue that maybe a stem cell transplant is what she needs, okay? The question then becomes, well, what are the risks? What are the safety about where you're doing it, right? This was your question. Where would you do the transplant? There's less experience in South Africa for doing transplants of older children in the 20s, okay? So could you afford, is there a group overseas that might be interested? Or is this actually, you're just going to, you know, we don't have enough information to say definitely if you carry on, you are likely to get another lymphoma or another thing. We don't have that information. I can't give that thing. So this is where genetics become more complicated, right? So now it looks like we do have a gene diagnosis, okay? What's good about this from a point of view of if she was to have children, this is a girl, again, because it's a heterozygous mutation, meaning there's only one faulty copy, she's unlikely to pass a disease onto her children, okay? So the point is that, and it looks, yes, which is unlikely. It would be very, very bad luck. It does happen. It does happen, but it's very, very bad luck, okay? So, I mean, what I'm saying is not enough to say, don't have children, right? So, yeah, so this is where it's a bit more difficult. That's why I put this case up, right? This is an active case I have ongoing, talking to a family about this, and I don't know at the moment whether there is a right answer, okay? And this is where discussion with your individual clinician is important. And this is also a field which is, you know, it's a field where, because all these cases obviously on their own are often quite rare. So, you know, primary immune deficiency as a group is common, but the individual gene defect in that person is quite rare, right? So to find other examples, and this is where it's very, you know, this is why I like to go to these meetings, because if I didn't go to this meeting, I wouldn't see this poster. I wouldn't have any idea. I wouldn't have found that other family to be able to think about this problem. And so it's a small network, and, you know, people are all speaking, and it really helps to be seeing these things, because you can get some idea, because that's one of the problems with these gene defects. Yeah. CMC is that chronic mucocutaneous candidiasis, a fungal infection. Yeah. Okay, this is another option. This is another case, right, that we saw. This is a 4.5-year-old girl from Joburg who came down to see us at Red Cross. She got no family history of primary immune deficiency. She was born premature. And the reason she actually came to see us is she would keep getting severe fevers, right? She had she came with a book, and her mother had mapped out her temperature. And this girl would be playing out in the jungle gym, come inside, she had a fever of 39, right? Fever of 40. They were putting this child in a bath, trying to cool them down. And when the fever was very, very high, the child was very pup. But then they kept looking for infection and never finding any, right? Never find any infection, right? Okay. And so she had essentially unexplained fevers, right? Okay. She was growing, okay, which is an important thing, right? So she wasn't like the child that gets recurrent sicknesses tends to develop what we call failure to thrive. They don't grow normally, right? Okay. Then she had these, when we investigated her, what she had was these kind of teeth, okay, which are not normal. They're conical teeth, okay? And they are a sign of what we call ectodermal dysplasia, right? Okay, and so essentially after a long workup for primary immune deficiency, we concluded, hang on, I'm just checking my. Oh yeah. So I put in, hang on. So we concluded that she had an ectodermal dysplasia. And ectodermal dysplasia have another group of genes, okay? And they're part of, you can sometimes have autoinflammatory. So it's a different part of the immune system that's overactive essentially, right? Okay, and the ectoderm affects other part. That's why you get the skeletal and the teeth problems, okay? But what I put here, this is just to give you some idea before I talk, because the next section I'm going to talk about what we can offer, right? So you remember how in the first couple of cases I showed where I thought the gene was a particular place, I sent it to a group that looked only at that gene, right? That's called single gene sequencing, right? So you think that it's a defect in STAT1, like the chronic mucocutaneous, you send there, you sequence that gene, and that's the answer, right? Then the next thing we can do is these kinds of what we call targeted gene panels, okay? And that's what's really expanded rapidly. And I'm going to talk to you about one that we're currently using now, the Invitae panel, right? Okay? But what that is that's where they say that we know the common primary immunodeficiency genes, right? So there's about 250 genes, or 220 to 300, they're constantly changing. But these are the common genes that map with immune problems, like in current infections. So what we'll do is we'll only look at those genes, right? And the advantage, okay, is that the cost is considerably cheaper, okay? The next thing is that you can, you can look at specific like groups of disorders, okay? And the thing about though is the advantage is that it's quicker, the turnaround time, the bioinformatics, the computing, we were talking about the computing, that's much easier to do, right? And then the other thing about it is that there's something called gene depth. Okay, so this is where it gets a little bit technical. But when you sequence the gene, you often sequence it multiple times to look at the copies, how many copies of a gene you might have. And for if you look at a single gene versus say sequencing everything, you can often look in more detail at that gene, right? And in a gene panel, you can look at the genes you have in that panel also in more depth, right? The disadvantage is you miss certain kinds of abnormalities. You miss big deletions in genes sometimes, right? And some things called copy number variants. You can miss some abnormalities. That's the one thing. And of course, it might not be a gene problem in that. It might be somewhere else. You'll miss that too. Right? So that's the disadvantages. Then you can do these two approaches. The one is whole exome sequencing. That's what I talked to you about that we did for my young girl. All right. And that covers all the protein coding regions, right? But you can see here, it's only 2% of the whole genome, okay? Its price is higher and basically and most of it's restricted to research groups, right? okay? There are some you can send away to overseas groups for around about this cost, $800, about 10,000 Rand. Here, you know, Monica's group, probably about 15,000 Rand, okay, for whole exome sequencing. And then the advantage is that you cover more variants, more genes. You can identify new problems that you might miss, okay? And the issue around it, though, is, again, you can have issues with sequencing depth, okay? So you can miss particularly genes that, you know, are the difference between highly expressed genes and low genes. You might not pick that up. So some defects you cannot pick up, right? Okay, on an exome. So there are still things that you might miss, okay? And then there's whole genome sequence, and that you can see is still quite expensive. The advantage to that is that looks at everything, okay? And immunology is becoming more and more complex. And what we're seeing is that you can actually sometimes you can have 2 gene abnormalities that lead to a particular phenotype, right? So you might have a gene problem in one gene, and if you look in a family, there might be more members of the family with that gene problem, but the way that they present look very, very different. And what we're finding is that there are gene modifiers. So the person that's more severely affected might have some kind of other modifier, or the person that's less affected might have a favorable modifier, right? And so that's where the future of immunology is going in terms of the genetics, right? Is to understand this in a more complex way. And this is one of the things about genetics in general, right? Because I'm sure that even if you put primary immunodeficiencies away, you'll see that now you can get direct to the public testing for different genes, right? I'm sure you've seen this advertised. You can go to DNA and Me, 23andMe. There's a South African company called D-Analysis. They offer, you can have any number of these small gene abnormalities that are linked to, you know, you struggle to metabolize carbohydrate, you are going to struggle with this drug. You know, there are all kinds of things that are rapidly expanding. And so this field over the next 20 years, we'll link more and more genes to problems, right? But we still kind of somewhere in between, and it's constantly changing, right? So you might do all that, and you might discover a whole lot of things that you don't know what to do with, right? At the moment. So that's one of the problems, okay? But that gives you some idea of the cost. So this was in 2017, and this is now back to the little girl I was talking about, all right? So again, the single gene test, we knew some people in Argentina, okay? And we looked for particular abnormalities in this gene, and we found nothing, okay, in that gene. And then the question was, what to do next, right? So then it was like, well, we actually brought the child down to Red Cross, and we looked carefully, and we actually said, well, we think this is this group of conditions. And apart from the fever, which was which was potentially disabled, we actually weren't worried about this child. Child was growing well. Hello.
So there was absolutely no infection anywhere.
Your ectoderm is important for your skeletal development, but it also controls your sweating. So actually the child has a problem with thermoregulation. It's a thermoregulation problem. So it's like the child will exercise and then they won't sweat properly. The temperature will go up. But on its own, the temperature is not related to an infection. That's why I mentioned this CRP, which is a marker of infection, and that would not rise. So it was isolated. So after extensive investigation, we actually realized it was probably not that harmful. You know what I mean? For the child. Actually, child's growing well. We looked at these lung thing. We didn't think there was an infection. So now we were like, okay, well, we've done this genetic test. Now what, right? What do you do next? Okay. So I've mentioned that already. So this was like what we have as options, right? So there's a group of people studying these, what we call periodic fevers, right? They're a consortium called Eurofever, and they were an option, right? There is a panel of other genes, you can see here, that we could target. And what's interesting is I put this figure up because this is now the Invitae Lab group. They are the people that we are currently using a lot, okay? But I look here, their price at that stage, this is 2017, was $475 for that group of genes, right? Their current panel is $250 for 250 genes in 2 years, right? That's how the field has changed in terms of the cost of doing these things, right? And as you get bigger, you can get cheaper, okay? And then look here, then there was the other thing. We were in contact with whole exome sequencing, and I'm going to show you the data that they've published from this university, Nijmegen, right? And that stage, you could get 1,800 euros for whole exome sequence, right? But, so this cost, the family couldn't afford this, right? We didn't have that much extra research money around. And yet now we've got a clinical problem that we were like, well, I'm not sure, right? And how is it, you know, if we pick up a gene abnormality in that, how is it really going to help us? So in the end, this girl has not had genetic testing, right? We've reassured the parents, patient, you know what I mean? They're much better. We've reassured the treating pediatrician, and the patient is, the last time we heard from them, they're doing fine, right? And yet they don't have a genetic diagnosis because of the costs. But maybe it's something we should reconsider, like now, 2 years later, because now it's half the price, right? So it's not, so this is another point in like, well, it's good to make the conversation, but maybe the conversation you have at one time, maybe you should have the conversation again every couple of years. No. Okay, so that's the other thing about it, right? So it's not a static thing, but I'll put this up. Yeah, I'll put this up to show you. So now what we have available, 2019, is this Invitae gene panel. And what they have is they've made it even more appealing. What they've said is, number one, if you send your genes to Invitae for the index case, so let's say you're a patient and you want a thing, the primary immune deficiency gene panel covers 205 genes, okay, for $250. If they pick up an abnormality, they will screen the entire family for free, okay? If they don't pick up an abnormality within the group of conditions, so let's say I'm looking at primary immunodeficiency and I'm not looking at, say, ectodermal dysplasia, if it's negative, for free, they'll also allow me to extend the panel so I can look wider if I want to, right? So they're offering all of that for $250, right? Okay, which is now quite a advantage. This panel has largely replaced all the developmental effort that ANPATH put in to develop their own panel here in South Africa, which also covered 200 genes, but they couldn't really bring the prices down more than about 19,000 Rand, okay? Because that's how long it took them to develop. And so that's how quickly the field is changing. They put in a lot of R&D to try and set that up. And now basically it's cheaper. The global market is now, it's cheaper to do a company, you know, so it's a...
Is I allowed the additional free that gives them more data to work with? Basically, just increases the pool of data that they've got.
So fast that now, what they're actually doing is when you send them their genes, they sequence everything. It's the bioinformatic programs that they're applying to your gene that is what's costly and what they're charging you for, right? And the interesting thing is, so it's of no extra cost to them to look at extra genes. Do you know what I mean?
As you were saying,
so that's why they're offering it, because they can, and it's easy. And it's just a software thing. They've done all the work already. When you send them the gene, they sequence everything anyway. So they know what your whole exome looks like. It's just that they're not analyzing it, because the analysis is what takes the human time, the computer time, all those things, right? But the actual sequencing, they've done, and they do it. So it's like they sequence everything with the same technology. You know, their machines for sequencing is the same, no matter what you're picking. And then they're applying different groups afterwards on a computer level. And that's what you're paying for. So they've made those pipelines shorter and quicker to analyze. So that's why they can offer it to you cheaper. So that's why it doesn't cost them anything really to extend it by a couple of genes. So that's why they're offering that. It makes it more appealing because you might miss it, right? Yeah. So, and then I can say like for some specific problems, we know people that are interested, like research groups that I'm talking about. And if you really suspect a single gene, you can go for it, right? But you can miss it. And then often that takes time too. So if you're in a hurry, that's, you know, you may want to go for something that's definitely likely to give you a more common answer. And then a whole exome sequencing, I mentioned that price there. And there are other groups already in South Africa. This is the Center for Proteomic and Genomic Research, which actually sits just down the street here, right? They're also starting to offer these pipelines, okay? So, yeah, so this is now that, remember I showed you that from Nijmegen, the Netherlands data. So this is their recent publication this year. And this really, I think, is for important information for patients and parents to take on board, right? And this is the realistic expectation of what you can expect from genetic testing, right? So this is where they took 254 patients from 249 families. This is all within suspected immune defects, right? And they put them through whole exome sequencing. They picked up a genetic defect in 72 patients. So roughly just under 30% of patients that they looked for, right? Importantly, the genetic diagnosis altered the treatment of the patient in about a third of those patients, right? So in a third of those patients, it actually meant that they had a different treatment approach, because now we have some defects we have specific treatments for. I mentioned stem cell transplant, but there are even some other targeted immune therapies that we might give in specific immune problems, right? I'll put this up for you because this is, you missed this here. So just saying, this is the Netherlands data with whole exome sequencing for patients with immune problems. They had 254 patients, roughly 250 patients from 249 families. They picked up gene defects in about 30%, right? So 1 in 3 cases, roughly. And similarly, furthermore, of those 30% of cases, there was about 1/3 of them in whom the treatment really dramatically changed, right? So those are, I think, currently what we expect, right? Okay, and then if you look at other studies, earlier studies that were done in smaller numbers of people, they were probably better selected and the rates were slightly higher. So the yields were more like 40%, okay? And then you can see here, you do lose something when you go for a targeted panel, right? So those in vitae panels, it's probably even slightly lower than that, right? And as it becomes more wide, so in other words, you spend less time in narrowing down who you're selecting, so the likelihood of actually getting something will go down, right? So the more genetic testing you do in general, the less likely you are to pick up something. Whereas in the past, we used to wait until you were like, had multiple things. We were really sure that you had a gene and the yield was much higher, right? In that way. Okay, but those are, I think, very realistic understandings. And this was the pipeline, right? So you can see, oops, this is worth looking at from a patient understanding point of view, right? You start here with a clinical phenotyping that's describing what diseases they have, what manifestations. They would look at the blood cell population, so some immunology, basic, and that led them to these 254 patients. I think genetic counseling is absolutely essential if you're going to consider gene testing. I think it just reiterates a lot of these points that we're discussing about today, but also not just, I'm talking very generally, they will personalize it to your particular family situation. They then often this exome sequencing, okay, for known primary immune deficiency genes. You can see here they picked up 62 abnormalities, okay? And you can see here they looked from a gene panel, they picked up the most of them. When they looked at the whole exome, which I've talked about, they picked up a further 10 patients, okay? And then here, if you didn't have that, then they looked for novel mutations, right? New things that are not described, okay? And here they then picked up, these are the people that agreed, okay? And they then picked up 10 extra possibly disease-causing mutations, right? Okay. And then what they've done is they've put these patients with negative results into a pipeline where every time new genes are coming, they will still keep looking again. You know, so as new things emerge in the literature, they will keep going back. This is what I was describing, how a new thing you can miss. And if you don't have the bioinformatics to look at a particular region, you might miss these important variants, okay? And then the other thing is that this is what mutations were only considered disease-causing in cases this exact same mutation was described before, or the genetic variant score class 4 or 5 in the guidelines, right? So that means it's pathogenic or very likely to be pathogenic, and that means disease-causing, right? Okay, and for an additional 12 patients, we identified novel gene variants in known genes with phenotypic overlap. What that means is that these genes, according to other cases or even mice immunology or other things, may be problematic, okay, novel variants, but they say here, functional consequences of these variants are unknown, right? What that means is we are not sure how they actually relate to the disease, right? And then this is also, I think, very useful to look at here, right? This is the yield based on what the likely presentation was. So you can see here, if you had isolated bacterial infections, these are the common patients that have recurrent respiratory tract infections, your yield was about 24%, right? If you have what is it? Pathogens, autoimmune reported in PID. Yeah, so this is the cohort of patients, okay? And the percentage of patients with genetic diagnosis per pathogen and disease, right? So this you can see here. If you only had a fungal infection, you very rarely, that would be like one fungal infection that was severe. You almost never find a problem, right? Okay, in the genes. Isolated autoimmune disease, lower. You can see here, combined pathogens and disease phenotypes. So this is like the young girl I was describing, right? She has infections, she had an unusual endocrine problem and some other hematological problem, right? You can see here, those patients have the highest yield, right? Almost 40%. So that you can see how, you can see, and this is now looking at the level of different immune abnormalities. Here again, the multiple immunophenotypic defects. So in other words, the more problems you have, the more likely you are to pick up something, right? Does that, I mean, it makes sense inherently, but this is it's important to understand when you think about yourself as a patient. The difficulty is always that you might want gene testing earlier before you develop the multiple types, right? In case you do have that. So you might actually, as a patient level, still want to be screened, even though you know that the yield is low, because I've only got this one manifestation. And if I'm going to get others, then maybe I want to know so I can be more alert or have more monitoring, right? Okay, and then this is what I was talking about. So when in that other slide, they talk about grades or class 4 or 5 variants. So what happens is when they find something, they put it through all the software like I was describing to you guys, and then they come up with, is it pathogenic? In other words, is it a known mutation? That would be a class 5 variant, okay? Is it likely pathogenic? Or is it likely benign, or is it this group? Uncertain significance. And that's the major problem, right? Is you can now have these testing, and this has happened already, people that had the AMPATH panels, people that have had all exome sequencing. The report you get back, and now you're sitting with a patient, and it says variants of unknown significance. Now what? Okay? This is part of the reason why it's important to have genetic counseling for your thing, because actually talking about this is really important for you to understand that this is a possibility and then what you might do about it, right? So it all stems from this fact that the field is moving so fastly that the primary limitation of genomic diagnostics is the lack of functional evidence provided by sequencing alone. And what that means is you pick up a variant, you put it through all the software, it may be significant, but you haven't done the work to confirm that that abnormality leads to a problem in protein, either in function or expression, in some cells or in the body or anything. We just don't know, right? And often that pipeline of work can cost thousands of dollars to just prove for one defect. Okay, so it's like, might not even be done, right? And this is what I'm saying is a lot of these defects, even that mutation I showed you in the 14-year-old girl, that hasn't got functional, we haven't done the functional assays to demonstrate the biological effect. Okay, so even though we say the variant's there, we say the software looks like it's maybe significant or unknown, we don't know, we don't have the functional work to show. And it's very hard then to be sure to base kind of any kind of clinical decision-making on those variants, right? The other thing that can happen, which I've seen as well, is that you get a variant, so you think it looks like something, you get a variant in another gene that seems to be totally unrelated. Like you can't tie up that abnormality to any published literature on what that gene looks like. That's very complex. You know what I mean? In fact, you think it should be tying up with another disease. I've seen this before. There was a gene abnormality in a young boy that came out that was linked to autoimmune hemolytic anemia, but the child was having recurrent infections. So like how the parents or the doctor was supposed to make sense of that, very difficult. Right? And that's when you have to bear in mind because that to me is like the risk of the process, because that can leave you as a family with more uncertainty than you went in with, not with reassurance in any way, right? So that's the risk you take, which really is why, you know, it's not just a knee jerk, every single person should have genetic testing, because you might land up with that situation, which is now more emotionally troublesome for you than a situation where you never tested at all. So that's what's something, and you do need to talk through that and consider what that means for you and how that would affect you as a family and emotionally and as a patient. So that's all I have to say. And I thought to now, like to open it to you guys and to anyone here that might have questions or might have comments about what they see as advantages or disadvantages for them, or you can ask me about specific questions or logistics related to your cases or any other issues. Yeah, we've got another sort of 20 minutes or so. And also, let's see whether I can now see the questions and answers. You want to have a toilet break? Yeah, no, sure. Sorry, man. Have I just talked so much? Sorry. Oh, coffee. Okay, good.
Jonny, on a totally generic basis, it's quite interesting. What I've always thought that like the more people get genetically tested, almost like fingerprinting, the bigger the pool is. But am I correct in what you've highlighted here is that unless you've got sort of a clinical background associated with that patient's test, is the genetic testing then fairly meaningless, or can they still be quite a lot of...
So for instance, there's no question that those initiatives are underway. So those initiatives, so for instance, like in the UK, they've been running the 1,000 Genome Project, right? So what that is that you are 100% right in the sense that, like, one of the only way to look at pathogenic, or for the software to learn what's likely to be pathogenic, it's very helpful to have reference genomes, right? So the first genome sequence was only finished, they only finished the Genome Project, Human Genome Project, only finished in the 90s, the late 90s, right? And one of the issues is whose gene did they sequence?
Yeah.
Right. So that was just one genome, and obviously you need to know what all the possible variants are, especially in all those non-coding regions where it becomes more. There's obviously a lot of heterogeneous. There's a lot of junk that probably has a questionable effect even on kind of cellular function. Right? There's some redundancy.
Yeah.
There might be a lot of different variances that are actually completely normal functioning. So there's no question that doing what you're talking about, which is increasing the reference pool, will improve the genetic testing that we do. So that is initiatives that are ongoing globally.
Even if it is just to show what is baseline, what is normal.
Correct. Yeah, you want to show what's normal variants, right? Because you see, you might screen, like, so when you do whole exome sequencing, you might get 200,000 variants or 270,000 variants. Now, how do you narrow those down to what could be problem? Well, you can look at specific places. So that's like you think where you know the gene is going to be problematic, or you can compare to reference sequences, or you can compare to families. Now, one of the problems with comparing to families is that some diseases have variable penetrance. And what that means is that you and your child might actually have the same gene, but your child may be sick and you might be fine. Or you might not be quite fine. You might have, I don't know, some fatigue, maybe you have painful muscles, or maybe, you know what I mean? Like we discovered this for X-linked chronic granulomatous disease, which is a neutrophil problem. It only affects boys, this X-linked form, right? But if you look, and one of the ways in which we diagnose this, we always take one of the parents' blood. Usually, we take the mother's blood. She's the carrier, right? And you'll often see that they will have two populations. The mother has a population of abnormal neutrophils. There's now a whole slew of publications on the fact that those mothers are not normal. They have various diseases and manifestations. They're not very badly affected, which is why they're not in hospital and all those things, but they carry the gene abnormality, and that's affected them.
It affects them in other ways.
It affects them in a different set of ways, right? So, and that's the problem slightly with excluding variants based on families. So like you say, well, neither parent is affected and the child is affected. Now you screen those genes and you say, we're only going to look for variants in the child which are not in the parents, like novel, because you also get spontaneous abnormalities or gene defects, right? That happen as part of human recombination, or why we're all slightly different. Okay, but the limitation of that is the parents might have a variant that's pathological, but just not penetrant. So they didn't actually manifest with any symptoms, and yet the child has.
They've just sort of been dealing with it.
So that's why we will get better at this. The more of these huge, massive endeavors we have to sequence reference human genomes, we will get better. And we also have the other thing is about populations. We have to secret different ethnicities, different populations. There's all kind of genes, variability, right? You know, African populations, we are the oldest human Homo sapien groups. We have the most genomic variability in our gene sequences, and we weren't part of the reference genome sequence. Not part of the European. We have to do our own genome project, which is now there are a whole lot of African continental genome-wide initiatives to do this.
That's what was interesting to me is that probably not solely, but largely at the moment, the genes that are mostly being sent for specific analysis like this are invariably someone who has got severe enough symptoms to warrant the costs.
Correct.
So most of their data at the moment is already someone who's got a problem with their gene, but they've surely, as I say, the more of the general population that tests, the more you've got.
But that is going on. That's going on. Those initiatives are underway, and computers
probably play a massive role in this, because I mean, from what I understand, the type of processing power just to do like one test is massive, isn't it?
Yeah.
So I mean, 20 years ago, it would have taken them like a month to do a test. Now they do it maybe in like a day.
Correct.
So I think that is huge as well, and obviously more data is.
Yeah, and that's why the costs are coming down. Yeah, eventually this is all. Some of the limitations that are computing. Some of them are technological. Yeah, and that's why the field is moving so fast. It's not only are we discovering new things, but the technology is getting faster. Your ability to have all these things is.
I mean, that first exome sequencing that took them something like 12 years or something. I still remember. I didn't quite fully. I mean, I'm not in that field. I'm in computers, so that's why the data aspect is interesting to me. But when they completed it, it was like in the medical field, it was massive. But then it was amazing to see how long it took them then and what they can do now in the time.
I've seen a slide by Francis Collins, who was head up the Human Genome Project, head of the NIH, and he shows how sequencing of the human genome time-wise has come down from like 12 years to like a day in the process of like 30 years. Yeah. That's all.
We could be one.
Birth your children sequence.
Oh, so that you mean they already have that data on file?
Yeah, you'll have the data file because you'll know what they shouldn't have. It'll give them side effects. So you can have you could have one sort of what they call a SNP, which is a single nucleotide polymorphism that makes the one gene more likely to do one thing, and yet in the same metabolic pathway, you could have another enzyme whose SNP goes the other way. Okay, here we go. Hang on. So here's a specific question from Susanna Goff. I'm just going to read the question to everyone so that you can know here. The question is, I'd like to ask if I would need the genetic test for my son. He's 15, CVID, but the family had rheumatoid arthritis, aunt, and also great-granny had it. Great-granny died of Crohn's disease, mother had Hashimoto's disease, an entire mom's part of family, including cousins and second cousins, have allergy, pollinosis, eczema, asthma. If we need it, where should we start? That's a very good question, and that's right up the field that I work in, which is good. So one of the interesting things about CVID, CVID, for those that don't know, stands for Common Variable Immune Deficiency, and it's the commonest antibody deficiency, and it tends to affect people in their early 20s, although it can affect children quite commonly, but often the diagnosis is only in the second decade or third decade, okay, or in adolescence, okay? And CVID is thought predominantly to be a polygenic disease. And what I mean by that is that if you go looking at the gene pickup, you are likely only to pick up, as we've shown here, very consistent, about 10 to 15% with a specific gene abnormality. So that would still be the yield likely in Mrs. Goff's son, okay? That would be what we would expect if we look in genes. But what's actually very common in common variable immune deficiency families, which is why we know that it is to some extent linked to the genes, is exactly the family genogram like you're describing there for your family, right? Where you see variable manifestations. You might have one child with a full-blown antibody problem. You might have another relative or a cousin that might just have an IgA deficiency, like a partial antibody problem. You might have relatives with autoimmune diseases, and you've described there the thyroid disease, Crohn's disease, allergic disease, and often typical common variable immune deficiency family trees look exactly like that, right? With different manifestations. And that in some instances might mean a specific single gene, but more often than not is probably a collection of unfavorable polymorphisms that have variable manifestations in different families. So to some extent, my answer to your question is that you would need to individually look at your son to see, does he just have antibody deficiency, or does he have some of the more severe manifestations associated with common variable immune deficiency in him, not just in the family. So in other words, does he have autoimmune manifestations, or does he have benign lymphoproliferation? Because there's a group of common variable immune deficiency patients that tend to be slightly more severe. And in that group, the yield of genetics for single genes, like I've been showing you, is much higher. So I think my answer is that I wouldn't necessarily knee-jerk to immune testing. But what I would do probably is first have a look to see what the spectrum is, and then decide based on that. So it's a possibility, depending on his specific clinical phenotype, whether I would consider doing that testing. And that's largely because CVID is typically this kind of polygenic picture most commonly. Yeah. But again, my the view is also it's also a bit of an individual conversation where you got to think about these kinds of things I've been saying about the variance of unknown significance or other things that you might throw up with genetic testing. If you were comfortable with that and happy to do that, well, genetic testing is now becoming so cheap and available that maybe you still want to do it just in case you throw up something that's unpredictable. But just in terms of clinical counseling, the family tree that you've described is a very typical family tree for common variable and does not necessarily imply that there is a single gene abnormality. Does that answer your question? Hopefully, sure. Type an answer. Anyone else got any?
Sort of linked to that, we've got two boys with CVID. Older one is Fairmount, what's the type of gamma globulinemia.
Yeah.
If the genetic testing were to show something specific and positive, what would what's your recourse? What is the treatment process? Or they're on polygam at the moment, which is more, I think most of the patients here know it's more fight with medical aids because it's prohibitively expensive.
Yeah.
But alternative to subcut or intravenous, what are other? You've now mentioned.
Yeah, so I don't think that it alters if you've got pure antibody deficiency that needs antibody replacement. That's pretty straightforward. Like you don't need that.
Yeah.
Where it helps you is in predicting autoimmunity and these other slightly more sinister manifestations related to CVID. And there are now some gene defects that have a CVID-like phenotype. A good example is Ctla4 deficiency or LRBA deficiency. They are recently described gene abnormalities which fall into the CVID family. And they have specific roles in the immune system where we have, for instance, we have a Ctla4 agonist, right? We have specific drugs that can target those pathways. And so if you were to find that gene defect, number one, you would have a knowledge a bit about what may present. And when it did start to present, you might have some thoughts about using these targeted therapies.
But that wouldn't necessarily change if immunoglobulins are working now. That wouldn't necessarily change the alternative.
No.
It might create an alternative treatment path.
We know you're still going to always need to use the immunoglobulins. Where it becomes useful is if you pick up something that's got a specific agonist that you can use. But that's, again, I would say that, in that I showed you about the 1/3 of cases with a gene having a treatment effect. I would say that the 60% where it doesn't really have it's the patients that are already on immunoglobulins, where you now got that thing. You're not going to do anything specifically different at that time. You know what I mean? That's I think useful. I think it becomes, where it might tip the balance is if you want to have another child, but you know what I mean? That's,
sure, thanks.
yeah, but you know what I'm saying? That's where, where you might think, okay, well, if I now have a gene, if I pick up a specific gene defect, maybe I've got 2 kids, I'm going to think twice about having another child. Or even if you've got 1 kid and I've got, whereas if you've got a polygenic disease, well, you don't know what you're going to get. It's not, I don't think then it's wise to say, oh, you shouldn't have children because you've got this, you know what I mean?
I mean, with 2 boys.
And that's where I find it useful actually to have a negative result. Okay, because if you have a negative result, you can also say it's unlikely that you've got a monogenic disease in your family. You know what I mean? In which case, then it's in a way like if you were thinking about another child, well, you'd say, okay, well, I'm going to take my chances. Do you know what I mean?
But with 2 boys, I mean, they still got 10 years away from that at least, hopefully. But I mean, then genetic counseling would be essential for them going forward when they have kids.
So correct. So when they are older, they might be persuaded to have genetic testing. Do you know what I mean? I mean, to some extent, so this is where it becomes about you as individuals, because you have to think how you're going to feel if you turn up one of these funny variants and you can't make sense of it. Are you going to be okay with that uncertainty? Do you know what I mean? And then again, the other thing is that you might think about gene testing now, and then you might look again in 10 years when things are more advanced. Because remember how I showed you, the first time I got that wrong. One people told me I didn't have that, and the next time. So you know, it's like, it's not a one-time only kind of thing. In 10 years' time, we might have 450 genes that we know of and variants that we now looking at differently. And then it might be different. So, but you know, you might want to leave those decisions to your own boys. Do you know what I mean? And then again, you might want to individualize. If one of your boys gets more sick at a later stage or something else develops, then you might think, okay, this is the time to do the testing, you know? So, but again, if you, and then obviously medical aids are not yet paying for it. So cost is another factor. So, you know, do I have, you know, 4,000 Rand? Do I have 4,000 Rand that I'm wanting to spend on the fact that I'm going to get a 20% chance of finding something and maybe 5% chance that I might find something that I don't know what to deal with? You know, then, and if that's okay for you, then you might want to go for it, because in some ways I find personally, if it was me, I would find the not picking up anything to be reassuring as well, in a way, in a different kind of way at the moment. Doesn't mean there's not something wrong and there's not something genetic. It just means there's no clear thing right now that I should be doing. As you say, there's no treatment that I can be doing differently. I'm doing my best as a parent and as a doctor. We're doing what we can, you know, like at this time, and accepting that in 50 years, we might have a whole different view of this whole thing.
But right now, sorry, on that, I don't know all the time, but immunoglobulins are immunoglobulins. I mean, if you picked up something in the genetic testing, it's not like they can target immunoglobulin therapy. No,
we can target other pathways of the immune system, but immunoglobulin therapy is immunoglobulin therapy. Yeah. So I'm just going to answer these 2 questions. Do you mind? So Janet's asking a question here. Hi, Janet. My daughter was diagnosed with PID at 9 months after numerous pneumonias, TB, etc. Her diagnosis is CVID, but the doctor thinks possibly some type of combined immunodeficiency. My son has just been diagnosed with CVID at 13 years old, so basically very different presentations. We did the AMPATH PID gene panel on my daughter, but it was all negative. Do you think we should do further testing on one or both of them? So that's also another question that's definitely worth a discussion. And I would say, yeah, probably I would think that there is a limitation in the targeted gene panels. And I would say that if you know, the fact that you have a daughter that has had very young presentation, so that's 9 months, that's in her first year of life, then the TB would worry me. You know, babies are not supposed to get TB, and my question would be whether or not she actually had BCG infection at that an early age. And again, that would be that's I think why you thought about the genetic testing with the AMPATH PID panel. And then, as I've shown you, that there are limitations with each of the tools tested. So I do think probably in your situation, Janet, I probably would think about moving forward with exome sequencing. At the same time, you have to be aware from a counseling point of view that you're still only likely to pick up something in about 30% of cases. But I think that, you know, your children are still young, and, you know, that's, certainly your daughter has shown herself to have a more severe phenotype such that the discussion of the combined immune deficiency has been raised. I think those patients with CVID plus, and one of the pluses is more like a combined or more severe opportunistic infections, those are patients that I do think I would prioritize for testing, and I distinguish them slightly from the pure antibody deficiencies. Then there's one other question here from Judy Dorfling. My son is diagnosed with specific antibody deficiency. He also has some other problems like speech delay, balance problems, stomach issues, recurrent infections. His doctor's suggestion, whole genome sequencing. Would the sequencing give us a more certain answer or not? So I think that my answer to that presentation would be the opposite. So I think that specific antibody deficiencies tend to often go with IgA deficiencies and much more mild immune phenotypes. And I think your yield in those situations will be much lower. You're probably looking at yields of, based on that slide, 8 or 9% or maybe even lower from that type of testing. And I think personally, whole genome sequencing is what I mentioned. I don't think we have as yet the knowledge to implement and understand those gene abnormalities in a clinical setting. So I think in whole genome sequencing, in your family's situation, you would pay upward of 20,000 Rand for that. And I think you might get information that you don't know how to practically implement. And I think that's the problem. So one of the advantages of going the route of a targeted panel is that we understand more about those genes. And consequently, we're more able to understand them, what they could in the most instances. Where you start to go to whole genome sequencing, you're going to turn up things definitely there that you're not going to be able to know what to do with. And as a result, as a family, that might just create for you more insecurity. And, if you've got a young son, maybe you want to wait till the son's older and, you're not going to be thinking about his children for maybe 20 years from now. And so at that stage, maybe rethink, because by then the field's moving so fast that we would have a whole different approach. But I think to spend that money right now with that presentation that you've listed there, I don't think is advisable. So I wouldn't be agreeing with your doctor's suggestion there. I hope that answers your question. You've got a question.
Sorry, I've got a very different question. It's not about gene testing.
Okay.
I'm being an adult patient with CVID.
Yeah.
And the limited treatment options that we actually have available. So I am on polygam and I struggle with polygam therapy.
Yeah.
So I actually get central lines every time. Veins are a problem. Central lines are becoming a problem. I don't want to port. My doctor's contacted you a few times.
It's Helen.
Yeah.
Oh, yeah.
Over the last few years. What I actually contacted the Immune Deficiency Foundation just out of desperation last month.
The Immune Deficiency Foundation, you mean in America? Jeffrey Modell.
Yeah.
Yeah.
And they actually said to me, because I'm like, I want to do subcat with this note. And I was on Intragam before it became out of stock. And
It's back. It's coming back.
They haven't told me, but I didn't know. I thought you heard it from you. But so then I'd love to go back on Intragam.
Yeah.
But they actually suggested that in America there's like 12 different IVIGs and like 15 different subcats. They said to me, why don't I try to do polygam, very alternative here. Just mix it with like very little saline and do it regularly subcutaneously.
Definitely do Intragam. Yeah. I mean, if that's it's back. It's in the pharmacies. Yeah. I received. I'll pull up.
Best news ever. I'm supposed to go back to hospital on Monday, but I'm prolonging myself again to just give my veins a chance to every month. But sometimes I leave it for 6 to 8 weeks. So I had a really bad experience last month. And we just mixed up the central line excision. And I got a hematoma, and I could literally not move my neck for like 5 days. And and then they wanted to put a report in. I'm not happy with it. I don't know, Dr. Peter, what do you think about reports?
I don't think a port's a good idea. Here, look here. So UPD Cape Town has stock of Intragam. Any private hospital, Clicks Pharmacy in Cape Town should be able to order the stock. Eastern Cape, UPD Port Elizabeth, any Clicks Community Pharmacy, private hospital. There you go.
That's awesome.
Otherwise, you could register with Discovery Medically, which is Southern X, or Medipost. Both Dischem Clicks have chronic medicine service. We're rolling out supply to other pharmaceutical wholesalers next week.
Yes, it's back permanently.
There you go. Well, it's back permanently as long. You know that. You know what? I mean, it's atrocious the supply, to be honest. And I wish I could fix it in some way. But the real problem lies with the fact that in any country you should have multiple products registered, right? Because all products go out of stock. It's the nature of a plasma-derived product. So, you know, you can't blame a company or get cross and whatever. It's like there's virtually no immunoglobulin company in the world that hasn't had stock shortages at some point. Correct. So that's why when you have products registered that are so, but the problem is that actually primary immunodeficiency patients use a tiny fraction of the immunoglobulin. So immunoglobulin companies, to make money, to stay alive, okay, have to really fractionate the hell out of all plasma, right? So they sell like hemophilia products, they sell albumin, they sell like immunoglobulin. So they've got a whole portfolio that they need to keep going, right? So they can survive, because fractionating plasma is hugely expensive, okay? And so essentially, like, immunoglobulin is one aspect. So for a company to come into a country, okay, I visited the, now I'm forgetting their name. I want to call them Biopharma, but they're not. They're the British fractionator. And I was looking at the map of like where they were registered. And I was like, how the hell did you land up? They were like in Costa Rica and like some other place. And I was like, how the hell did this all work out? And they said, it's got nothing to do with supply. It's got to do with regulatory registration, costs, ease of getting into markets. It's got nothing to do with what you think it should have to do with. Do you understand what I mean? And so it's all got to do with like where it's cost effective for them to be. And it's all, unfortunately, it's all business. Do you know what I mean? It's nothing to do with like patient care and whatever. And that's our problem. The problem is in South Africa, the regulatory environment is not very favorable. And what the government has said is that like they've said, we've got our own fractionator, right? So we should protect that fractionator. What they don't realize is that fractionator is you know, variable, can go out of stock, can change, right? And so they haven't made it very easy. And look at Octogam, you know, like, and you know, they were trying to bring Gamma Norm. Gamma Norm is supposed to be getting registered for the last 5 years or 8 years or 10 years. I don't know. I mean, you know, Monica said to me, well, it's always been getting registered. Like every time you ask them, they say next month it's going to be approved by the SAPRA, right? And yet here we sit like so many years later. It might be another 5 years now that MCC's changed to SAPRA. You know, like, so these are the difficulties. We're dealing with all those kind of vagaries, which is really tough for patients, right? Because, you know, you do land up with situations like yourself where you're forced to have a port or something, which is crazy, you know what I mean? Or central lines or something every time, which is horrible. It's basically, it's a thing, but it's not, I don't know how to unpick it. We're fighting ongoingly with discovery, right? That's an ongoing fight to get beriglobin allowable, but also beriglobin is just ridiculously expensive. I mean, it's like, do you know what I mean? It's like, it's not feasible. And we've told beriglobin that too, but CSL Behring are not prepared to compromise or something. You know what I mean? Like, so that's the thing when it comes to business, like people are like, well, we don't, and the problem is the primary immunodeficiency market is too small to have any influence. Do you know what I mean? It's like, we're too small of a lobby to bother any company. So if we say, oh, well, we're not going to use beriglobin, we're going to use another product. Well, they don't really care. So that's a problem. It's like we don't have enough of a lobby to really be able to swing things one way or another, you know? And so that's why, yeah, we just have to like make do, you know? And we try. I mean, you got to keep chipping away, right? Sometime, again, maybe we'll be more successful in a few years' time. Maybe Gamma Norm will finally get registered in the new SAPRA, you know, all those things. And I think we do have to keep kind of shouting, you know? Unfortunately, that's how these things work. You got to keep shouting about your problem. No. Well, I mean, no, but hang on a minute. No. Polygam is subcut and in intragam. That's what intragam is. Intragam is subcut polygam, basically. It's the same plasma. It's got a few differences, but largely it's the same. Do you understand what I mean? So, and yeah, the thing about intragam, so the thing about intragam is registered for intramuscular use, and it's basically then used off-label subcut, right? Which, and then, so NDI is looking to develop and this development is ongoing, a 20% product, which they will register for subcut use. Okay, they're even thinking of maybe putting hyaluronidase in it. But that's, unfortunately, the timelines for these things. I mean, we develop a new product, it's maybe 10 years. That's a reality. But that's why Intragam is coming back as it was, right? This is, and they said there's stock, for the foreseeable future. But I mean, make what you will of that.
And he's actually a twin. So we had luckily with one about 10 years ago, we had the genetic testing. So it was found out he's got mutancy, so it's X-linked, and I'm a carrier, and so is his twin sister, Paige. So where do you go for genetic counseling? And what is, I mean, obviously she knows.
Yeah.
So is it like one day when she wants to have children that you would kind of like take her somewhere and discuss it, or what is the genetic counseling for?
Yeah, so I mean, this genetic counseling is readily available, right? So I mean, Ampath have got genetic counselors, Stellenbosch, UCT, but genetic counseling, I mean, in an X-linked condition like that is like, well, it's quite easy for your daughter in the sense that if she has a son, the son will be affected. You know what I mean? So some gene defects are not as simple, and oftentimes you go for counseling before you have the defect. And then the counseling that might be relevant to her was, are you going to have genetic selection? Now that is got its own set of counseling. It is available in South Africa at a cost, okay, where you can select embryos that are female. You know what I mean? Like you can do that. And so that is the level that we operate at a cost, and overseas you can do that. And again, that is a whole genetic counseling conversation in itself. And that's the kind of counseling she might need to go for. More than, yeah, exactly. She's not going for a counseling of like, what we're going to find, whatever. We like, you have this gene, you now considering children, these are your options. This is the risk, because again, that therapy has risks. You got to take out an embryo, you got to fertilize it. You can only select it at the zygote, the gap that's actually to be fertilized, and at the zygote stage, taking one cell of that might have an impact. We don't know. I mean, it shouldn't, but we don't know 100%. That's the kind of issues that got to be discussed. You understand what it means? So that's what she would go for, a specific kind of counseling. And yeah. We can. There are centers that I actually talked about this the other day, because somebody asked me about this for hereditary angioedema, which is an autosomal dominant condition, and they were wanting, and it's fascinating because in that particular condition, and this is actually interesting in relationship to X-linked gamma, you might even have the same view, is that like they felt like, my American collaborators felt like the treatment for HAE now has developed so much that people should have a normal quality of life. Therefore, the risks of messing with early embryos doesn't justify to them the selection of the condition. Now, this question was raised to me by the grandmother who is affected by this condition, and about her grandchildren, and she feels very differently about it, because the care of HAE in this country is not necessarily the same as the care in America, right? X-linked A-gamma might be the same. X-linked A-gamma globulinemia is a condition we know that if you get onto immunoglobulins early, you tend not to get any bad autoimmune manifestations. You tend to just get infections. And if you can deal with that and you're onto it early, well, maybe you could argue that you can cope with that. But you might have a very different view. Do you understand?
I think right now, if I just sit down and say,
yeah.
What do you think? What's on? She'll go like, oh my gosh, I don't know do that as a parent.
Yeah.
And he's healthy, like
yeah.
right now, but in his 22 years, he hasn't had like a bad time, actually.
But that's what I'm saying to you. It's very different. Exactly. The doctors might have a different view to the patients, and then to the sibling, to the parent of a child. Yeah. So what I'm saying is that's where the counseling comes in. That's what I'm saying. That is what counseling is. The counseling is about taking all those factors, sitting down, and really making the decision for yourself that you feel empowered to make, with talking through with somebody that's got the knowledge to advise you on what the risks are, what will happen, what are the different things. And what I'm saying is that's a particular kind of genetic counseling that's required, which relates to manipulation of embryos. Yeah. And again, that technology is also improving because there are all kinds of conditions like that. You know, cystic fibrosis is another one. There are all kinds of genetic conditions where people are thinking about that. Can we select out embryos that will not be affected? And what are the risks of doing that? Yeah. I think we're going to wrap it up there. Is that all right? Good. Excellent. Well, thanks for coming. I hope it was helpful. No worries. Stop. Presumably you have to stop and share.
Perfect time.
He hasn't been discussed. I mean, I've heard about all the discussions around parent, but I haven't heard anything recently. And they were talking more with Steve Holland from the NIH.
Yeah, because
to be honest, Steve knows much more than me about.
Well, he's the specialist in intermittent 12
Correct.
defect that he had the problem.
Correct.
But he's
Correct.
had the stem cell transplant, and his main problem is he still can't eat. I mean, he was hospital again last 3 days. He just can't eat. Now, I can't understand. Maybe you can explain it to me why the stem cell transplant hasn't. Well, it has worked in that he's on very. It has worked. And that he's on very global with it. So that's
the thing is,
infections.
Yeah. So the thing is that I mean, stem cell transplants have their own problems.
No, he nearly died. He had, I mean, it was horrific.
But I heard about him having a very sort of cytokine storm.
Yeah, the cytokine. Yeah. Storm.
So the thing is,
and just if he hadn't gone to Red Cross, he would have been dead. Yeah. So we had a really
I heard
hard
about
time.
yeah. So what I'm saying is, so that's the thing about so stem cell transplants themselves have problems. Do you know what I mean? Have complications. And immune reconstitution is unfortunately not.
It's taken a
always
year.
perfect.
His blood's been shocking.
Yeah.
He got sick again. Right down.
Yeah, correct. So
that they were thinking of putting him on steroids to try and do food trials, but they can't do anything until his blood's come up. And they take a long, long time.
Yeah. So that's the problem. So I mean, he may not have had complete take of his transplant.
Yeah, but the fact that it took a year to start of getting vaguely normal.
That's still within reason. Still within reason, although it is getting to quite late. And that's why I'm saying I heard about the fact that it was a bit delayed, and that might indicate that it's not perfect. Which is why, you know, that's what we hope for is complete reconstitution where you can come off immunoglobulins. Yeah, you can, unfortunately. It's not, you know, we want it to be exact, but there are problems with it. That's the issue. Because he had a haploidentical. Where did it come from?
Both his parents are recessive.
Yeah, so it comes. So did he not get it from one of his parents?
Got it from both.
No, but I'm saying, where did he get the transplant from?
Oh no, a donor.
A donor, yeah. So it was a haplo. It was a matched.
Oh yes, sorry, yes.
Matched, non-related donor.
No,
unrelated. Might.
We found out
Okay. But I'm saying so. Yeah, correct. So what I'm saying is sometimes in those donors, it's not 100% take. You know, it's not as good as having a related donor. Usually. So, I mean, the outcomes have been globally really improving for matched unrelated donors. So normally,
why would that be? Why would it improve?
Why is it improved? It's improved because of the preconditioning regimens.
Of the donor?
No, of the patient.
Of the patient.
Yeah. So it's like I mean, transplant immunology is.
No. Dr. Esther speaks to us and we like.
Yeah. But the thing, I think that the problem is that we want, when you transplant someone, you want them to be 100% reconstitution. Unfortunately, there are patients in between. You know what I mean? The difficulty is when you have defects that are not that clearly. So I didn't even touch on that, right? Because there are now several defects. Like I touched on this a little bit with the young girl in her 20s. There's several defects that look really bad, but we're not sure about the transplant.
Well, he's having a full genome.
Yes, correct. Yeah.
I think they're doing it at the MRC now. Where
they're doing it, I don't know which building, but Brigitte. Yeah,
Yes, yeah.
I don't know where her building actually physically is. It's in their mosque. But so yeah, so you know what I mean. We want it to be.
So where does that leave us? You say the most extreme.
No, where it leaves you is that you, to be honest, is wait and see. You have to go bit by bit by bit and see
But
what.
he still can't eat. He's going to be fine. He's never had a morsel. He just still lives. He's got a
Neocate.
neocate. He's now junior, but clinically,
Neocate.
yeah.
But how's his weight coming?
He's amazing. Well, my daughter's a doctor. She, in the beginning, she wouldn't believe it. Child, diarrhea. It's just horrible. It's the weirdest thing.
Yeah, I mean, I haven't spoken to Monica enough about him to know in depth. You know, to be able to give you a really informed. What I'm saying to you is that the like counselling lies in the nuance of his case. You know what I mean? To give you the correct.
Yeah, we'll be waiting for now this full report.
Yeah. Look, I mean, the point is.
And then all the factors that you mentioned will come into place.
I mean, like, so what I'm saying is, I can give you some broad outlines, but actually what's needed is talk specifically about this case. You know what I mean? And then I don't have enough detail to give you adequate counsel.
Okay.
Sorry.
No apologies. I just wondered if Monica had
she hasn't talked to me.
There's a big team. There's Davidson and Claudia Gray.
Yeah.
Everybody's got a great team.
Yeah.
Yeah. My daughter takes terrible strain.
So, yeah, I mean, the parents, I must say, you know, having my own kids now, it's so tough.
No, it's hell for me to watch what's going on. I mean, he was in hospital again. Didn't get temperatures. Now he's getting temperatures. And yeah, it's a tricky one because now he's had the most experience.
Yeah. But I mean, yeah, I mean, I can say good luck. Not at the moment. After the end of the month. Yeah.
Because Eric got was very low to try and make it less traumatic. That biofeedback, you know?
Oh, yeah.
Is this maybe because she didn't know about it?
But she's not using subcut. She's been using